Hi, class. We are going to talk about asthma today. This will just be not too long of a video, and then we'll pick up next week with the rest. So let's get started. Let's see. Okay. So asthma affects at least 25 million people, and actually it results in 3,500 deaths per year. I think we forget that people can actually die from asthma attacks. It is a chronic inflammatory disorder causing limitations in the airflow. It is usually reversible, however. And usually what happens is there's some triggers there, whether it's an allergen or some exposure that leads to this inflammatory response. And what you see is a bronchospasm, edema, and excessive mucus production. And this is kind of the pathophysiology in a nutshell. You get the inflammation causing the bronchoconstriction, the edema, and the narrowing of the airways. The mast cells are activated by the irritant, and they result in the release of several mediators, including those histamines we've talked about, bradykinin, prostaglandins, cytokines, leukotrienes, these further exacerbate the inflammatory response. You get increased blood flow, vasoconstriction, and then fluid begins to leak from the vasculature. You also attract white blood cells, you have increased mucus secretion, and that bronchial restriction. Some of the things that are risk factors for exacerbations, of course, are allergens, but also respiratory infections. Some people have issues when they exercise, sometimes change in weather, exposure to certain things, even foods and additives can result in an asthma attack. So that's just the pathophysiology in a nutshell. Again, this is a list of some of those things that can cause it, and allergens and environmental factors. We can have inhaled things such as dust, pollen, and then drugs and different foods. Sometimes the additives in the foods are actually the culprit. There's always air pollution, and then there's occupational exposures that can be a trigger as well. Respiratory tract infections, and also psychological factors. Stress, anxiety can increase the number of asthma attacks someone's having. Asthma sometimes goes hand in hand with GERD. And again, exercise. Sometimes people only have symptoms when they exercise. Our hallmark symptoms of asthma are episodic wheezing and dyspnea, cough, and sputum production. The most common symptom of asthma actually, however, is cough. And usually this is treated symptomatically and often leads to a delay in the diagnosis of asthma. So you may have nothing but cough. And so it kind of gets put aside as, okay, they've got a, post-viral infection, cough, or, so they treat the cough, but asthma is never really identified. When somebody's in a really acute asthma attack, they'll have breathlessness and a lot of anxiety, wheezing, and sometimes the coughing as well. Just a list of other symptoms in addition to the wheezing, coughing, and dyspnea. You may get chest tightness, prolonged expiration, feeling of suffocation. And then if it goes on too long, you're going to start getting symptoms of hypoxemia with the restlessness, anxiety, heart rate goes up, blood pressure goes up, respiratory rate goes up, not be able to have a conversation because they're so dyspneic. They may start using their accessory muscles, and then they may become cyanotic and diaphoretic. In a severe asthma attack, if you're hearing inspiratory and expiratory wheezes, and then if suddenly you have a decrease in breath sounds, that's really an ominous sign. This means they're not moving at all. So it's not a good sign that suddenly their wheezing stops. When you're assessing asthma, we do have classifications of asthma. We're going to go over that. But you're going to want to classify their asthma because this will guide your recommendations for their care. You want to know if it's a mild intermittent, if it's mild persistent, moderate persistent, or severe persistent. Make sure that you get a good family history. Often you'll see some genetics involved. You want to know what their allergies are, and some people will require allergy testing. Also look for eczema, because this inflammatory response and these allergens also often go hand in hand. People who have asthma, especially children, often have eczema as well. We want to ask them the frequency of their symptoms. How often are you having symptoms? Are you having issues waking up at night, having an asthma attack? How often are you using those short-acting bronchodilators or your rescue inhaler? Are you able to perform your normal activities? And how often are you having an exacerbation that requires oral corticosteroids? Some diagnostics. PFTs are one of the first diagnostics that we can do. And remember, in asthma, they're going to have a decreased forced vital capacity, decreased FEV1, FEV1 FVC ratio, but they will have an increased total lung capacity and an increased residual volume. However, the difference here is that they actually will respond to a bronchodilator. They will actually do that. There's also some tests where they will actually try to induce an asthma attack by exercise or by giving them an inhalant, that methacholine, that will actually kind of be a trigger for an asthma attack. Some other things you might do is chest x-rays if you suspect a respiratory infection, allergy testing. Sometimes, again, they may have an infection. You may have to look at sputum, white blood cell counts. We don't do a lot of blood gases unless you're in the inpatient setting, but usually somebody who's in an exacerbation will present with a respiratory alkalosis. However, if this goes on too long and then become hypoxemic, then you may end up actually moving to a respiratory acidosis. But in the beginning, it'll be respiratory alkalosis. This is a chart that tells us how to rate our asthma. So again, those questions I talked to you about will help you decide where this person lands. So let's say you have somebody that they are using their short-acting bronchodilators about 4 to 5 times a week, and they are waking up occasionally at night, a few times a month. They're symptomatic, not daily, but more than 2 days a week. Then this person's going to be diagnosed with mild persistent asthma. You can also look at your FEV1s as well. Somebody with a mild, either whether intermittent or persistent asthma, their FEV1 will still be greater than 80% of predicted, and their FEV1 FVC ratios will be normal. Once you move to more of a moderate persistent asthma, where they're having waking up at least more than once a week in the night, they have daily symptoms, daily use of the bronchodilators, some limitation of their activities, that's when you see the FEV1 begin to decrease. It'll still be greater than 60, but less than the 80% of predicted. So this is what you're going to look at. In addition to those, the symptoms and the use of bronchodilators, you want to look at how often they're having an exacerbation that requires oral corticosteroids. Anybody with mild persistent forward usually will have, greater than 2 a year, either 2 or more a year. When you're looking at the management of asthma, your goals are we want this under control. We don't want people's life to be affected, their ability to do the things they want to do. So we want to make sure they can have normal activity levels, normal exercise. You want to maintain that pulmonary function as close to normal as possible, and prevent exacerbations. Focus on finding the triggers. You want to try to minimize any adverse effects from their asthma medications, and of course prevent mortality from asthma. We also will develop an asthma action plan, which we'll talk about shortly. So a key thing is to identify what causes an exacerbation. And one of the ways we can do this is with a daily monitoring at their peak expiratory flow. This gives you a really good idea, especially if they do it on a daily basis. Sometimes they can catch a flare up before it really begins or gets too bad. And this is a video that just kind of shows you how how to teach them to do a peak flow meter. You want to make sure that they also get written instructions on how to manage an attack, a lot of education, and you may at some point refer them to a pulmonologist. The respiratory peak expiratory flow rates, these are to monitor but not to diagnose asthma. It tracks a patient, how well their asthma is controlled. It shows how effective their treatment is. It recognizes signs of this flare-up before it really happens and helps to guide your action plan. The technique for the flow meter, you want to make sure you give really clear instructions. You want to demonstrate. They usually have demonstrators available. You move the indicator to the lowest end of the mouthpiece scale and attach the mouthpiece. Inhale very deeply, and they're going to do this standing up. Then they're going to place their mouthpiece in their mouth with their lips closed tightly around it and blow out forcefully and rapidly. You're going to want to write that number down, repeat it 2 times, and then record the highest number. And this is how you're going to get your daily readings. And you want to know what is 80% of their personal best. So how you calculate that, you're going to, so they can have a number to go by, is you're going to do these peak flow readings twice daily for 2 to 3 weeks, usually when they get up and somewhere between noon and 2. And also before and after taking their quick relief medication. So once they've determined what 80% is for them, then they are able then to monitor their asthma and see where they stand. If they fall in the green zone, 80 to 100%, we're good. They're in good control. They're not having asthma symptoms. They keep taking whatever meds are prescribed as usual. Once they fall into the yellow zone where they're 50 to 80% of their personal best, that means caution. So you may have to increase their medications. And red below 50% signals a medical alert. You must use your their inhaler, their rescue inhaler quickly to open up their airways, and then call their provider immediately if the peak flow does not return to yellow or green and stay there. Asthma diaries can be very helpful. There's many different ones available that you can look at. These are really good to identify triggers to help them figure out what is causing their attacks. And of course, if you have them do an asthma diary, make sure that they bring it with them to their next appointment. And this is just an example, but it's a very fuzzy one, but of an asthma diary. We want to know the time of day they're most likely having asthma attacks. We want to know what they were doing when it happened, you know, what environment they were in, and that just helps you to figure out what the triggers could be. So talking about medical management, first of all, we have rescue therapy. And this is what we use for quick relief of bronchospasms when they're having either an acute episode or an exacerbation. And usually we're using short-acting beta-2 agonists or SABAs, and that's either albuterol, which is either Proventil, Ventolin, or levobuterol, which is Xopenex. In some cases, we also use anticholinergics such as Atrovent, and sometimes we use this in conjunction with a short-acting beta-2 agonist. In addition, if somebody's having an exacerbation, a flare-up, oral systemic corticosteroids are also given to manage this flare-up. So those are your short-acting meds to manage asthma attacks and to manage exacerbations. Long-term therapy is another thing that we use. One of the things is inhaled corticosteroids. I gave you, and this is to use on a daily basis, not just when they're having an attack. I gave you a few there to look at. Pulmicort, Flovent, there's several of them. Advair has one, but it has something else in it as well. And the other is long-acting inhaled beta-2 agonists like Cordial, or Ceravent. There have been we usually give something else with the long-acting inhaled beta-2 agonist. So typically what you're more likely to see, they may start them on an inhaled corticosteroid, but if they want to add something, they usually give them a combination medication such as Advair or Symbicort. These have an inhaled corticosteroid and either a beta-2, a long-acting beta-2 agonist. And this is what helps to guide what we choose to treat with. If they're just having intermittent asthma, then you're just going to prescribe them a short-acting bronchodilator just to use as needed. Once we move up, if they're not controlled, they're having to use their short-acting too often, that's when we move toward a low-dose inhaled corticosteroid. Those in asthma, that is your next step, is inhaled corticosteroids. Of course, you continue your short-acting bronchodilator as well. As you move up the chain, inhaled corticosteroids, you can move to a higher dose, or you can add a LABA to it. Again, when you move up the train again, you're a medium dose with the LABA, high dose, and then at some point you may even have oral corticosteroids or some of the new medications like omalizumab, which is for patients who have persistent severe asthma. There's some other things to consider along the way here. Some things like some of these other medications that can help control, like a leukotriene inhibitor, can help with their allergies, cromolyn. Some of these can be added to the other medications. We rarely use theophylline anymore, but these are some of the add-on medications. So what you need to know, SABAs are first, then you're going to add a low-dose inhaled corticosteroid. From there, you're going to either increase the steroid dose or add a LABA to it, then you're going to maximize those doses. And then from there, we will move to something like omalizumab to help with their persistent asthma. Really important to teach them health promotion, to identify and avoid triggers, prevent exposure to things like dust mites, cockroaches, pet dander, extremes in temperature. Some people are very sensitive to aspirin, and NSAIDs may exacerbate an attack. Want to maintain good weight, control their GERD symptoms if they have that, and you want to treat these individuals promptly when they have an upper respiratory tract infection. You'll likely move to antibiotics a little quicker in this population. You want to promote good nutrition, rest, exercise, and good fluid intake as well. Just good, healthy lifestyle living will help control things. Really need some good education on their medication. You want to make sure they know what it's for, what the dosage is, and really important that they know how to administer it. We have a lot of different methods of administering asthma medications. We have nebulizers, we have just regular inhalers, we have spacers, we have disc, we have a lot of things. So they need to practice in front of you. You need to demonstrate, they need to practice, they need to be able to show you how to use it properly. You want to know, they will need to know how to clean the device. Make sure you give them printed instruction as well as demonstrate. Over-the-counter bronchodilators, I think Primatene Mist is the one that come to mind, actually make asthma worse, so you want to teach them to avoid that. Inhalers are expensive, so sometimes people kind of give up on taking their prescribed inhalers and will move to something like that. But if they're having trouble affording, you need to get your staff to look at the patient assistance program and try to get them what they need. This is an example of an asthma action plan. You're going to make this, different for different people. But if you look at this one, this is kind of a standard one. there's green zone, 80% of personal best. If they move to the yellow zone where they're 50 to 80% of their personal best, you want to have them do their rescue inhaler every 20 minutes times 3. If they get back to that green zone within an hour and stay there, then you want to have them use their rescue mat a little more frequently for 1 to 2 days. Sometimes we change the controller meds. It depends on the person, and how bad it is. If they don't return to that green zone within an hour, use the rescue inhaler again, and of course, contact their provider. If we get into the red zone with less than 50% of their best, then you want to use their rescue meds. Call their healthcare provider. If the symptoms persist more than 15 minutes, call 911. And of course, if they can't walk, they can't talk, they're cyanotic, call 911. This is another example of an asthma action plan. And this is really part of your treatment for these patients. The reason people die from asthma attacks is really not catching them quick enough. So that's why your peak expiratory flow readings are so important. When somebody has an acute attack or they're having an exacerbation, of course, we implement that plan. We use our rescue inhalers. You want to teach them to remain calm and their family to remain calm, and you to remain calm. You want to check lung sounds, how hard they're working to breathe, what's their pulse ox, peak flow, vital signs, do they look cyanotic? We want to teach people to use pursed lip breathing during these times. Of course, then we're going to treat them, but we want to teach them how to handle these things ahead of time. Status asthmaticus is, of course, a critical life-threatening condition. This is when they come in with severe dyspnea, a lot of terrible wheezing, using their accessory muscles. If you check their ABGs, they're bad. They may be confused, diaphoretic, agitated. And of course, if anybody happens to walk into the office or urgent care like that, this is a call 911. And while you're waiting on the ambulance, you're going to give them treatments. And if you happen to have oxygen as well. So that's all for asthma. I hope that wasn't too quick. We will continue on the rest of our content next week. Thank you.